So, Chapter 6, Human Body, we're going to talk about structure, function. We're going to talk about different body systems. We're going to talk about how most of those different body systems are all interrelated in an effort to keep ourselves as functional as humanly possible. So, in the video, they mentioned anatomy is how the body is made, the bits and pieces and parts that make up the body. Physiology is how those things actually work. Realistically speaking, anatomy is the easier portion, right? Learning what the parts are isn't always the most difficult part. Learning how the body actually uses those parts and what goes on inside of the person when those parts aren't always functioning at their best. So the physiology piece can be a bit more difficult. We're going to start off with some more term. You just saw all of this. The anatomical position, when we are identifying points on our patient, we use the anatomical position. Someone standing upright, facing forward, arms down, palms forward. So this is how anytime we're identifying an injury on somebody or a painful point or anything that our patient tells us, this is what we're going to use as the frame of reference. Next, we'll talk in body position. So when we find someone laying on their back, they are in the supine position. When they are laying face down, we call that prone. This is generally when we're identifying how we found a patient. We start setting the scene, right? We're the only person as EMTs in an emergency situation that actually get to see eyes on the patient right at wherever their injury or illness happened to occur. So when we're talking about how we found the patient, we'll say supine, prone, seated upright. We use those terms just so that everybody can kind of get a quick visual of what this patient was doing when we found them. It's not very common that people just decide to lay in the prone position in the middle of their living room. So that's going to be something that as we're describing how we found our patient to doctors and nurses and things like that, when we give report, we'll say, patient was found on arrival, patient was found laying prone in the living room and we just run from there. But right out of the gate, the people that we're talking to are going to say, well, generally speaking, people don't just decide, well, this looks like a good place to nap and lay down in the middle of the living room. So it is all in setting the stage before we even get to any of the anatomy and physiology and what's actually wrong with the person. When we talk about airway maintenance, we'll talk about the left and right lateral recumbent positions. This is also what for 1,000,001 years has been called the recovery position. Now, what I will tell you is we generally more often will use the left lateral recumbent position. If you think about the way an ambulance is set up, if we're going to lay somebody on their side and we lay them on their right side, what can't we do? If I have a patient propped up on their right side, are they looking at me or are they looking away from me?
Manage their airway.
Yeah, I can't see anything. I can't manage anything. Not to mention the one bit of, looking out for myself in this situation. If that patient vomits, they're going to throw up all over my equipment and it's going to be a nightmare for me to clean. So left lateral recumbent position gives us a view of the patient. We can watch their airway. We can watch them breathing. We can manage different problems as they come up. And if push really comes down to shove, the mop-up duty afterwards isn't quite as ugly. Most patients that we transport on a stretcher are going to be in this position here. Anything short of a 90-degree angle, which is the head of the stretcher sitting absolutely bolt upright, is called the semi-Fowler's position. It's also sort of a position of comfort. Most folks don't really want to be laid out perfectly flat on the stretcher. Most people don't want to be sitting completely bolt upright on the stretcher. And most patients, believe it or not, are well enough to be transported in what we would call a position of comfort. And this is what most people find it to be. If we were going to have a patient in full Fowler's, which is the back of that stretcher sitting bolt upright, generally that's how our respiratory patients would like to be transported. Anybody want to venture a guess as to why that might be?
Uh, the spine is straight up and the airway passage is open.
Yeah, it makes breathing just that little bit easier. And then if we start talking about some other, a little bit more involved things that can cause respiratory problems, any sort of fluid in the lungs is going to be pulled to the lowest parts of the lungs by gravity. So it leaves more lung tissue available for, the act of breathing and the act of ventilation and respiration to actually take place. So again, this is generally the transport for most patients. I'm going to skip right over this because this is not a thing that we do anymore. They used to call the shock position the Trendelenburg position. We transport patients with their feet up. We can actually elevate the foot end of the stretcher. And the theory behind it used to be that blood would get back to the trunk of the body where things are more important. What we never once thought of in all the years that we did some of this stuff, this position included, is we were actually putting pressure on the heart, the lungs, the brain itself. And we were, again, one of those times where story didn't follow science, and we wound up probably doing worse for people than we really meant to. So our friend there on Crash Course, he went over a bunch of this stuff. I started talking some of it yesterday when we were doing our little vital signs and lung sounds piece. We have different planes that separate the body into left and right, front and back, and a couple other spots on our person. So the midline connects straight through the nose, the lips, the chin, the umbilicus, and separates our patient into left and right, respectively. Anything close to that midline is going to be termed as medial. So anything right along that midline portion of the body, we identify as being medial. The further out we get from that midline, we'll start to call things more lateral. Proximal and distal, that means close and far away. So proximal are things on the person that are closer to that midline when we get out towards the appendages, the extremities. Things down by the fingers, we're going to term those as distal. Same with sort of the ankles and the toes and stuff like that. They are the most distal portions of our patient. The bottom of the foot is plantar. The actual sole of your patient's foot is the plantar side. The palm of your patient's hand is the palmar side. And looking at this patient right here, what's something that we can tell right away about their left and right? They're facing towards us. So what does that do to left and right, respectively?
It reverses it.
When we're talking from the patient's perspective.
Yeah, we're going to talk about everything from the patient's perspective. So when you're looking at somebody face to face, your right hand is closest to their left hand. Your left hand is closest to their right hand. And that's sort of, believe it or not, that's kind of a pain in the neck of a thing to try and remember. Next, we'll move over to the right side of the picture where the patient is turned with their side facing us. That mid-axillary line, someone who got the lecture portion of vital signs early yesterday during our meeting. What is that mid-axillary line? No? All right, that's all right. Mid-axillary line is another imaginary line that we draw through our patient through the middle of their axilla. The axilla is the medical term for our armpit. That mid-axillary line is where we're going to check our bottom lobe of the lungs when we listen to lung sounds. So mid-axillary, above that last rib. The mid-axillary line does something else, separates our patient into anterior and posterior, or front and back. That ventral and dorsal, that's not as commonly used, but if you get in a jam and you have to remember which one's front and which one's back, the dorsal fin of a shark is on a shark's back, not on a shark's front. So the dorsal side of a person is a person's back, not a person's front. Anterior and posterior is really what we'll use a lot more often. Moving right along, we got really the last little bit we're going to talk about. Next to that midline, we have the midclavicular line. So the midclavicular line is a line that goes through the middle of the patient's clavicle or collarbone and goes straight down the body. And that's the other spot we're really going to listen for our lung sounds. So when we're listening for lung sounds on a patient, remember, it's midclavicular line above the breast, midclavicular line below the breast, and then mid-axillary line just over the last rib. And when we're listening to our lung sounds, we listen on the patient's right and then on the patient's left, same spots. So midclavicular, then we go midclavicular above over here, then midclavicular and midclavicular below over here, and then mid-axillary to mid-axillary over here. Why do I do that? Why don't I just go down one side and then down the other?
Because you have two parts of the lungs on the left, right side. One side's got 3 sections, the other side's got 2 sections on the left. So to get an accurate assessment of his breathing and his clearance of his lungs, you have to check in that diameter frame.
Yeah, that's exactly it. I'm comparing all the different spots in each of those 2 lungs. So I listen one lung then the other because it gives me a better idea of, do these things sound the same? It's not always that they're going to. So I need to know what it is that is going on, and listening all the way down one side and then all the way down the other, especially in a situation that's pretty high stakes with a sick patient, doesn't really tell me a whole lot of good information because there's a lot of stuff going on. So if I go one side to the next and compare things directly one after the other, it gives me a much better view. So the next thing we'll talk about is how we break down our abdomen. When we are assessing the abdomen of a patient, any patient who has a complaint that warrants it, we draw a crosshairs right on our patient. It goes along the midline, and then it goes through the umbilicus from left to right, right to left, doesn't really matter. And it separates all my abdominal contents into left upper, left lower, and right lower quadrants, respectively. There's not much as emergency service providers that we're going to be able to do for patients with abdominal pain. Because if you look at all of the stuff that is in all of those 4 quadrants, all of the stuff that crosses from one line to the other, the liver's in 2 quadrants, probably can provide pain in 3. We have colon problems. We have GI. It's just so much. But it is important when we start getting into talking about abdominal emergencies, and then a little bit later when we get to the trauma lecture about traumatic abdominal emergencies, to at least know where some of these structures are in relation to the patient. There are certain things we expect from certain organs when it comes to either pain or injury or inflammation, discomfort, call it whatever you want. And without sort of knowing where that lives, it can lead us down a pretty wrong path. So there's not a whole lot of structure here to really have to nail down, but at least give it a little bit of thought when you're going through the chapter and when you are going through the slides and stuff, this is a good picture to maybe have a printout of, or at least go back to every once in a while to make sure you can identify the parts and pieces. The body is separated into a bunch of different cavities. Those cavities are separate for a multitude of reasons. First, we'll talk about the cranial cavity. The cranial cavity is built the way that it is to provide the highest amount of protection for the body's computer, the brain. Moving on down the line, the brain's job is to send out messages. Those messages would never go anywhere without an adequately functioning and protected spinal cord. The spinal cord lives inside that spinal cavity. Those two things together are what's known as the central nervous system. The central nervous system is the brain and the spinal cord, and really the job of those two things is to send and receive messages. The brain is sort of like the motherboard of this computer we call a body. Next, we'll talk the thoracic cavity. In the thoracic cavity, we have pretty much all of the rest of the main, very, very important right now type of organs. So we have the heart, the lungs, and what we term the great vessels. The great vessels are things like the aorta, which transports oxygenated blood directly from the heart out to the entire rest of the body. Every single drop of blood in your person passes through that aorta on its way to somewhere. And it doesn't really matter where that somewhere is, as long as the aorta is functioning and uninjured and not having any issues, blood's going to go through it. But in order for this machine that we are hoping to have continue to run for a very, very long time, blood needs to get back to the heart. Because if blood can't get back to the heart, all the beating in the world pumps nothing. The vena cava, superior and inferior, returns every drop of blood in your person to the heart in order for the heart to pump it out to the lungs so that oxygen can get picked up, and this whole process just continues and continues and continues. The main most important processes in every person is air goes in and out and blood goes round and round. The diaphragm is so here's a little bit of medical terminology. The diaphragm is the inferior most portion of the thoracic cavity, but it is the most superior portion of the abdominal cavity. The diaphragm is what actually separates the abdominal cavity and the thoracic cavity. It's a dome-shaped structure. It's a muscular organ, and it is integrally important in moving air from the outside to the inside. These are some things that we're going to go over at length today about just moving gas and exchanging gas, because without an adequate supply of oxygen and sugar, the metabolic machine that we call a body will break down in some pretty specific ways. And if we can sort of get some of that stuff at least understood, I'm not even looking for nailed down, we will be in great shape.
Sir, question.
Shoot.
The vincaria that's inside the heart, where you said there's a superior and inferior, do they relate to that in the test as the atrium, which would be the top of it?
No, the atrium is actually one of the two top chambers out of the four of the heart.
Okay.
That's coming up.
Okay.
Next, we're into the abdominal cavity. The abdominal cavity is what houses in the superior most, so in the top portions, all of our GI tract and all of the left and right upper quadrants that we talked about. So spleen, stomach, liver, pancreas, gallbladder, and in the back portion of that, both the left and right kidney. Now, as we get into the lower portion of the abdominal pelvic cavity, we start getting into more of the organs of digestion. So colon, the large and small intestine, and working our way out towards the bottom, we get into the now actual pelvic cavity, which is where things like the urinary bladder lives. In our female patients, this is where their organs of reproduction live. So things like the fallopian tubes and the ovaries and the uterus and all that lives in the pelvic cavity. There's no real divider between the abdomen and the pelvic cavity, so that's why they kind of list them together. The further down we go, the more we get to organs that are hollow in nature. The further up in the abdominal cavity we see a lot more solid organs. And when we start talking about injury and illness of those two things, there are some specific sort of patient presentations that we can look for. So knowing that more of your solid organs are in the upper quadrants and more of the hollow organs are in those lower quadrants of the abdominal pelvic cavity is probably best bang for your buck at that point. Now we are actually getting into the body systems a little bit. We're going to talk the skeletal system. The skeletal system really is the scaffolding for our entire body. It's got 4 functions. It's going to give us shape. It protects vital internal structures. Look at your rib cage and your skull, and that makes that pretty understandable, right? Big bony structures surround things that are very, very important. Some of the other things that that skeletal system does is it allows for movement. If we didn't have this skeletal system giving us shape and giving us the ability to articulate and move, we would just be blobs on the floor that stayed in the same place we were when this all started for us. Last but not least, really the 4th thing that the skeletal system is really integral in is the storage of minerals and production of blood cells. The bone marrow is where a lot of our blood cells actually are developed and formed and released out into systemic circulation. Our skeletal system is broken up into 6 basic pieces. We have the skull and the spinal column. We know that the skull is the head. It is the bony structure that protects the brain. The spinal column is the protection and structure for our spinal cord. Moving now towards the anterior portion, we have the thorax. Our thorax is our chest. Our rib cage makes up our thorax. Now we're going to move down. So we're moving now more superior, moving down our body. The next basic part is the pelvis. The pelvis is what connects our legs to the rest of our person and allows us to walk around and stand upright. And the last 2 bits and pieces, I'm sure this is no surprise, is the upper and lower extremities. Now, there's a whole lot of stuff labeled in this picture. What I'm going to tell you is you don't need to be able to label all of it. There's 206 bones in the human body, and I'm not going to ask you to name every single one of them. It's just not a thing that you're going to be responsible for. But when we start talking about splinting and extremity injuries, there are some injuries that you're going to need to be able to identify. So we have 7 injuries that we're going to need to know where they are, what they are, and how to adequately immobilize them. So first one is going to be, we'll start at the top. We have the clavicle. We can call it the collarbone, but know that clavicle and collarbone are the same thing. Next, we need to know where the scapula is. The scapula is the shoulder blade. It is the dorsal or posterior portion of your shoulder girdle. Next, we have the shoulder itself. So the actual joint that connects our arms to our body is the shoulder joint. Moving on down the line, our next 2 spots are the humerus And the joint that connects the upper portion of our arm to the lower portion of our arm is the elbow. Next, we have the ulna and the radius. The radius is right where we check for our radial pulse. So it is on the thumb side of our arm and is the bone that makes up our forearm on the top when we have our hand sort of in that anatomical position. The ulna is the bottommost bone. It's on the pinky side of our hand. And last but not least, we have the wrist. If we can remember these 7 spots, we're in good shape. Because when you get to the state exam, it would really kind of be a bad day to accidentally appropriately splint the wrong injury, right? If you're supposed to splint a humerus and for the life of you can't remember where the humerus is, so you splint something else, you wind up having to retest. Not a huge deal, but let's be one and done with everything. State practical, national written. Let's just have let's have a big party at the end of all this.
Excuse me, you said that you splint several of them the exact same way?
There are several of them that get splinted the exact same way. Clavicle, shoulder, and scapula are splinted identical. The wrist and forearm are almost identical. And the only 2 that are even a little bit different are the humerus and the elbow. So even if you're hedging your bets, you can go 3 for 7 just by guessing. But yeah, those are the only real big portions in the upper extremity that you're going to be responsible for. The only real sort of important things that I'm going to ask of you in the lower extremity are really the femur. The femur is the largest, strongest bone in your body. It is surrounded by the largest group of muscles. It roughly has the same tensile strength of concrete, and it causes a lot of problem and can be responsible for a lot of blood loss when we see fractures to things like the pelvis, the hip, or the femur itself. Other than that, a lot of this stuff is pretty self-explanatory. We have the ribs. I think everybody is going to be able to identify what ribs are. We have vertebrae. Okay, well, I think everybody pretty much knows that the vertebrae make up the spine. We'll get into the bones of the face and the skull here in just a second, but this basically, when we're looking at the skeletal system itself, don't make things more difficult than they have to be, right? If
Question,
it's
sir.
yo,
We're not going to talk and touch on a subject on the kneecap area, the patella, and the tibia and fibula bone at all.
maybe briefly when we actually get into injuries, but one
Okay.
of the things that you can notice right now about the upper and lower extremities respectively,
They get splinted somewhat the same.
yeah, they're structured exactly the same. So
Yeah.
any of the splints that we use on the bones of the upper extremity, we can really do the same for the bones on the lower extremity.
Correct.
It's just going to be on a larger scale.
Okay.
Good question. So that's enough on that for just a few minutes. Let's get into the skull. The skull is broken down into different regions because as we get older, the bones of the skull actually will fuse together and turn it into one solid, immovable bony structure. The cranium is the top and back sides of the skull. So it is the forehead and pretty much the crown, the cap of the skull. We have the occiput. We have 2 parietal bones. So the occiput, if you reach behind your head, you know that little like bump you have directly at the back of your head, that is the occipital region. We have the parietal bones on the sides of the skull. 2 temporal bones, one on each side, right where you rub your temples when I give you a headache in the middle of this lecture. And last but not least, we have the frontal. We also have bones in the face that make up the rest of the skull and the eye sockets, and the only little bit of actual bony structure in your nose is the nasal bone that sits between both of your eyes. The maxilla is the upper jaw, the mandible is the lower jaw, and the rest makes up the sides, and really the top of the eye sockets are the zygomatic bone, those are the cheeks, and the bottommost or inferiormost portion of the frontal bone is the top of the eye sockets. So looking at the skull right here, I know until I got a little deeper into this stuff too, I really thought, you hear about a fractured eye socket and you think it's not really altogether that huge of a deal. But looking at the structure and the makeup of the human skull, a fracture of an eye socket is actually a fracture of your patient's skull and can lead to a whole bunch of long-term type problems with control of the eye, vision, and really can actually lead to some pretty traumatic and significant things as far as injury and insult to the brain. I can remember being a kid and, you'd always hear about, oh, they got their bell rung playing football or whatever. And you never thought twice about it until, well, I've been out of high school for a long time. Until you get a little bit further down the road, now we hear a lot about traumatic brain injury, concussions, CTE, things like that. And injury to any of the bony structure of the skull, just because of the way it's made and because of the way everything is fused together and it's supposed to be solid and protection for the brain. If something has hit one of these bones hard enough to actually fracture it, all the structure underneath that is getting damaged as well. Even if it's not from the direct impact, if it's just from the fact that your brain is inside that skull, rattling around like a BB, then you're still going to have much the same outcome and a lot of the same injuries. The brain is not real conducive to being sort of batted around. Any direct impact to the skull can bruise the brain, whether there's bleeding and swelling or not. And with the way that our skull is made, what does it look like, you think, when the brain starts to swell? Do you think there's a lot of extra space in there?
No, it's got to compress against the side of the walls inside the head.
Yeah, it starts becoming under pressure, and I can tell you the brain does not like to be squeezed. And we'll start to see some pretty significant injury patterns and some pretty significant patient reactions when that brain is under that increased intracranial pressure. And then you add to it the fact that the most important part of the brain is the only part of the brain that actually exits the skull. The brain stem is what connects brain to spinal cord, and it's where all of the major respiratory control, all of the vital life function control for your body happens. And it exits the skull through a sharp hole that's only just barely big enough for it. So that increased pressure is going to go somewhere, and the only opening in the skull is what's known as the foramen magnum, which is the hole in the bottom where all the important stuff lives. And we start to see some pretty negative outcomes and signs and symptoms with our patients with just some increased swelling and pressure on the brain.
Do they use that funny terminology for the foramen magnum? Was it the Lewis something they call it?
Oh, the circle of Lewis, is it?
Yeah. I
Yeah,
think.
that is sort of a failsafe, right? It is a circle of vasculature around the brain. It is just one small little loop. It's like a rotary, and it is meant to operate so that the brain itself doesn't really suffer from loss of blood. It's meant to constantly be able to supply the tissues of the brain with an oxygenated blood supply until pretty much right up until the bitter end.
Okay.
So we have the spinal column right here in front of us. We have the cervical vertebrae making up the bones of the neck. There are 7 cervical vertebrae. They are, since we're not altogether that creative in medicine, they are labeled as C1 through C7. So cervical 1, 2, 3, 4, 5, 6, 7. The next group of vertebrae are the thoracic vertebrae. There are 12 thoracic vertebrae. They are connected to one each to each of the 12 pairs of ribs. The ribs will connect in the front when we look at the next group of pictures here.
I'm sorry, for cervical, did you say there was 1 through 7?
1 through
Yes.
7, yep. And then thoracic are labeled much the same way, T1 through 12. So the ribs, the thoracic vertebrae connect in the posterior portion to these 12 cervical vertebrae. In the anterior portion, they connect to the sternum or breastbone, and they actually make up the housing for our lungs in that fashion. It gives the rib cage stability. When we start talking about respiration and ventilation in a couple minutes, we'll talk about why the structure and function of the rib cage is so important. The 12 pairs of thoracic ribs are, for the most part, pretty sturdy. It takes, again, a whole lot of force to wind up with real true rib fractures. When we start talking about assessment of a trauma patient in a couple of weeks or so, we'll talk about some pretty significant injuries to our patient's chest wall that we can find and fix right away so that our patient's condition doesn't deteriorate in front of us. In the next couple of days, we're going to talk about, our scene size up, our scene survey, and our primary patient assessment. Our primary patient assessment has to do with anything that would possibly affect my patient's level of consciousness, airway, breathing, or circulation. And if I find a problem with one of those 4 things during my primary assessment, it's a primary problem and it needs to be addressed and fixed PDQ right this very minute, because if I don't fix primary problems right out of the gate, what do you think happens to the patient?
Cause a lot more problems and complications. Go to.
Yeah, none of the other stuff that I'm doing is going to be worth a damn, right? At that point, if you don't fix a bad airway or a patient who's in respiratory arrest or a patient who doesn't have a pulse, any of the rest of the stuff that we can talk about being able to do at some point is like peeing in the ocean to warm it up.
So it's always ABCs, air, breathing, circulation. To
Yep.
always maintain them.
When all else fails, circle right back to the ABCs in your primary assessment, because some stuff we can stay in the vein of talking about trauma, since we're talking about the skeletal system. Some stuff is a surgical fix. Trauma, real for life trauma, is something that can only be fixed by a surgeon. So all the stuff that I'm going to do on scene is just wasting time that this patient needs to make it to an operating room. So we concentrate hard and heavy on level of consciousness, airway, breathing, circulation. Sure, we do some things quickly to try and find any other injuries, but what we're really concentrating on are direct threats to life and addressing those, and then moving rapidly towards transport and fixing everything else on the way. Because bandaging broken fingers and putting band-aids on people who, have a blood pumping out of a femoral artery bleed isn't really going to do them any service. All right, so we just talked about the thoracic spine. Now let's talk about the lumbar spine. The lumbar spine is what makes up your lower back. We have 5 vertebrae there. They are the least mobile of all the vertebrae that there are. There's 33 total, and these 5, I will tell you, are the most immobile and biggest pains in the neck in the world. But most back injuries don't actually involve the vertebrae or any actual solid structure of your back. Most back injuries at least originate with a muscular injury. Always take care of your backs out there, fellas. This is probably what causes more than, I think the last I looked, it was like 70% of career-ending injuries are from backs.
Mm.
In a little bit, we'll talk workforce safety and wellness, and you got to do what you have to do to make sure your back stays healthy, core strengthening and all that kind of stuff, because I am working in an office now because 14 years ago at this point, I wound up with 13 herniated discs. So backs are no joke. Moving on down, we're going to get to the sacral vertebrae. There are also 5 of these. The sacral spine makes up the back wall of the pelvis. These 4 vertebrae are actually fused together and rigid to give the back portion of our pelvis structure and shape and stability. This is what the rest of the bones of the pelvis connect to, are these 5 fused sacral vertebrae. And then last but not least, we have 4 more fused vertebrae. We have the coccyx, or the tailbone. They are pretty much just the last vestiges of Darwinism. This is just the last 4 little bits of before we became human, when we were still cave people. The coccyx is pretty commonly injured in things like falls. They're not altogether that well protected. They're not as thick and sort of big and padded as a lot of the rest of these vertebrae. Your vertebrae and the rest of your spine has pretty rigid muscular structure around it that keeps it in line and doing the things that we need it to do as far as movement and function. So here we have our anterior view now. We talked about the posterior portion with all 33 of those vertebrae. Now we're taking a quick peek at our thorax. Our thorax is our chest. We have our 12 pairs of ribs right there. We have the clavicles, the anterior view of our cervical vertebrae, and all of these things actually make up a closed system for our lungs and the actual function of ventilation. When we talk about breathing, and we'll get into it pretty deeply here in just a little bit, but when we talk about how we actually breathe, I'll put it to you guys like this, because since you're all going to be firefighters, they send you guys up on a roof with a saw to cut a hole in the roof. You are ventilating that building. You are just trying to make gas move. When I take a breath in, I am ventilating my person. We're going to get into a little bit of the physiology about how all of that works here in just a couple minutes. But really, all I am doing is moving gas from the outside to the inside when I do what we call ventilate. The same thing goes as if you had a BVM in your hand. You are just moving gas from the outside of that person to the inside of that person. You are ventilating them. Respiration is when the actual business of that gas getting into our blood actually takes place and something actually happens. Until we have respiration occur, all we're doing is just moving gas back and forth. That make sense?
Yeah.
Yep.
All right. All right, I got about 9:40, so we're gonna take a short break here. When we come back, we will talk bone injuries, and then we'll get a little bit deeper into all the nuts and bolts here. By all means, if you have a question as I am yammering on, stop me and ask your question, especially with some of the stuff we got coming up, because ventilation, respiration, and all of that is going to rear its ugly head here again in just a few minutes. And we'll
I had,
start talking about the heart and blood flow and all of that.
I had a question on was it the radical part of the spine?
Okay.
T1 to T12. Each one of those parts of the spine, that vertebrae, that connects to a rib cage, correct? That continues down.
Yep.
Okay.
Not all of our ribs connect in the front. Hang on, I'll go back a couple and get to the front picture again. So
Because again,
not all of our ribs actually connect to the sternum in the front. The first 7 pairs of ribs are what they call true ribs that actually attach to the sternum directly. The next 3, so 8, 9, and 10, attach to each other and then attach to the sternum. And then we have floating ribs, which are really kind of the bottom pair that don't really attach to anything. They're in the back.
so 8, 9, and 10 are pretty much the ones that connect.
No, 1 through 7
1 through 7.
connect directly, and then 8, 9, and 10 connect together. And then the last 2 pairs don't connect in the front at all.
Is that something we should be aware about on tests or?
Not really, no.
Okay.
All right. So let's take 10 minutes, get a good decent stretch, get yourself another cup of coffee, and we'll get a bit further along into the muddy waters here.
So what time? 9. Return at 9.
I got about 9, probably about 9:50.
Okay.
All right.
Mm-hmm.
Okay, is everybody back and ready to get after it some more?
Yeah.
Yep.
Yep.
All right, here we go. We talked about the musculoskeletal system briefly here for a little bit. Now we are going to talk about some of the things that can be involved when there's injury too. So when we talk about injuries to the bones, we need to keep in mind that the bones themselves have a very large blood supply. So that being said, with all of that large blood supply, anytime there's an injury, we can have some pretty severe and significant bleeding that may lead to our patient winding up in a state of shock. Now, we haven't talked about shock yet, but when we look at the word shock, the actual medical term for shock is hypoperfusion. Perfusion means supply of oxygenated blood. So if we put hypo in front of that, that means low supply of oxygenated blood. The body will not run well and will not run for long if shock and hypoperfusion are allowed to persist. A single femur fracture all by itself can wind up with a blood loss of somewhere between 1 and 2 liters of blood just pouring out of our patient's vascular system. Now, your average adult only has about 4 to 5 liters of blood to begin with. So that means one broken femur can pour out round about half of our circulating blood volume. And unless it's an open fracture, we may never see a drop of blood on the ground. What we'll see a lot of is maybe some rigidity when we palpate over where that fracture is because of all that blood having leaked into the tissue. We'll see some swelling, we'll see some discoloration. When we assess a patient, we are using, at least sight, touch, and hearing as part of our assessment tools. So we're using 3 out of our 5 senses anyhow, and you can add smell into that a lot of the time too. That's probably the more unpleasant of the 4 of the 5 that we use. Please don't taste your patients. Sight, touch, hearing, and smell are going to be really things that just add to the picture we are starting to develop of how our patients present. And even things that seem simple, like, oh, it's just a broken bone, it's just a broken this, it's just a broken that. Pelvic and hip fractures can actually lead to even more blood loss than a broken femur can. And we talk about really severe, significant, life-altering bleeding that we may never actually see a true drop of blood on the ground because it's all internal. Add to that now that all of this bony structure is surrounded by muscle. So even more tissue that has even more blood supply. We have our muscles used for movement. So we have our skeletal muscle. We have muscles that are used for a number of other things that we're going to talk about here in right now. This skeletal muscle is attached to our bony structures. So the scaffolding has this muscle attached to it. Skeletal muscle is also called voluntary muscle. That means it is under conscious control of the brain and the nervous system. When I want to pick up my coffee mug, I have to reach over, pick up my coffee mug, bring it to my mouth, take a sip, and put it back down. That is all under conscious voluntary control. It makes my movements deliberate. It makes it something that I have to think about, and it makes it something that I actually have to physically accomplish. Next, we're going to talk about some involuntary muscle. Involuntary muscle, the ones we're speaking of right now, are cardiac muscle. Cardiac muscles are even a more specialized part of involuntary muscle. Cardiac muscles have what's called automaticity. Every single muscle cell in your heart can generate its own impulse to beat and to contract. Now, the heart does have its very own pacemaker that sends out that electrical current and makes that heartbeat nice and regular, nice and smooth, and everything goes just the way that it's supposed to. but there are times where we'll find an irregular heartbeat, or we'll see something like ventricular fibrillation, which is one of the rhythms that our defibrillator will actually shock. What we're trying to do is reset all of that chaotic electrical activity, and we're trying to get all of that heart muscle back to zero. And hopefully the pacemaker will pick back up and the heart will beat regularly the way that it's supposed to. We're trying to just reset everything. This cardiac muscle is special, and it's also a bit needy. The heart muscle itself, this cardiac muscle, cannot tolerate lack of oxygenated blood supply, period. Even for a very short period of time, if the heart muscle does not get what it wants, which is an adequate supply of oxygen and glucose, those muscles begin to die almost right away. They are completely intolerant of blood loss. And if those muscles die, what do you think they don't do anymore after that?
They don't contract, they don't work.
Yeah, they don't contract and they don't work, which means that piece of heart muscle is never going to function to squeeze blood out of it again, ever. So when we have a patient who's got a history of heart attacks, heart attack or myocardial, myo meaning muscle, cardial meaning heart, so heart muscle, and the last portion of that is infarction. A heart attack, the true medical term for that is myocardial infarction. Infarction means death of. So those two words together means death of heart muscle. And if that heart muscle dies, it's not squeezing anymore. It's not doing its thing anymore. And it is going to be really negative for your patient being able to now get out the proper amount of blood with every contraction. Remember when I was talking to you guys yesterday, I said the body doesn't do anything extra that it doesn't have to. So if only getting a little bit of blood out was enough, the body would be happy with that. It wouldn't need to squeeze as much as it does or as often as it does. So when we start to see pieces of our patient's heart muscle actually infarcting and dying, and they've had, a history of heart attacks, there are some certain things that go hand in hand with that, like respiratory problems, because the cardiac and the respiratory system are codependent. They depend on one another to function. Without us ventilating and getting gas down into our lungs, there would be no oxygen available for the heart to pump blood to pick up that oxygen, to then pump that oxygenated blood out to the body. And if those two things aren't functioning at optimal levels and working together in order to carry out the process of living, then sooner rather than later, those two systems will begin to take each other out.
Question, sir.
Sure.
So every time a person has a heart attack, that definitely affects them for the rest of their life. Like their heart would never be 100% again. That's something that would never be rebuilt.
Right.
Okay. So going further, that if a call happens and there's a patient and we find out information that he's had like multiple heart attacks in the past, we should probably proceed with a type of a caution of making sure he's getting oxygen at 100% most likely, because he's not going to probably be able to produce enough of the blood to pump it.
Yeah, well, see, that's kind of a 50-50 coin flip scenario right there too, because for the longest time, I mean, I got certified as an EMT in 2003. So when I was an EMT, if you stubbed your toe, we've got as much oxygen into you as humanly possible. Everybody got oxygen. Some is good, more is better. Let's pump as much O2 into this person as we can. And then some things have changed since then. As far as when you're treating patients here in the classroom and when you are testing for the state exam, I'm going to tell you now that yes, every patient you're going to come into contact with until you leave this building, put as much oxygen on them as you can. So they're going to get oxygen with a non-rebreather mask set at 15 liters per minute. So the same O2 bottle with just a different delivery system connected to it. And then I'm
Okay.
going to tell you, when you guys actually get out to the street and start treating the residents of the city of Everett, those rules don't apply. Because now we give oxygen only to people who need it.
Okay.
There is, believe it or not, oxygen's only important until you don't have any, right? There is,
Correct.
believe it or not, such a thing as providing too much oxygen as a medication. And it can have very, very negative consequences for heart attack patients. So someone who's actively having a heart attack right now, it can have very negative results for someone who's having a stroke. We make them worse with too much oxygen. I know it sounds weird to say too much oxygen, but
No, I hear you. But so out there in the real world, if something like that was to occur, we would want to not give them 100%. We'd want to keep it a really small flow amount to stabilize
yeah,
them.
out working in the street, really, unless they have a respiratory complaint to go along with their chest pain, or a
Hmm.
respiratory complaint to go along with, their signs and symptoms of a stroke,
Yes.
we might not give them any oxygen at all.
Okay.
But
I've got a,
in here, you'd be spot on to say, I'm going to give oxygen to everybody.
Okay.
I've got a question. When we talk about people who are overweight and that their hearts have to work harder, is this due to the fact of, getting clogged arteries and stuff like that? Or could weight also be a factor that it's kind of crushing the veins and the arteries a little bit?
A little bit of both. So we have clogging of the arteries because poor diet. That's how you get to be 400, 500, 600 pounds.
Yep.
You also have the weight of the that excess mass on all of the systems. So you'll see some compression and that sort of thing. And you also just have all of that excess person that now the heart has to pump blood to. Add to that, through living sort of that kind of lifestyle and having a poor diet and poorly taken care of, the blood doesn't stay quite as nice and fluid as it needs to be either, because then you start talking about things like type 2 diabetes and excess amounts of fat in the blood itself, and it just becomes a real taxing scenario for the heart and the lungs and really all of the important stuff.
Okay, thank you.
Yep. So the last little bit of smooth muscle we're going to talk about is called non-striated smooth muscle. The cardiac muscle is striated. The cardiac muscle has those pathways that will make them conduct the electrical impulses of the heart. These rest of the smooth muscle, the involuntary muscle that's non-striated, is found in places like the walls of blood vessels and around the digestive tract to change the diameter of things. So when we have a patient who, let's say, we'll stay with trauma here for just a minute, because we're going to talk about, shock briefly here. So when we have a patient who is involved in some sort of accident, let's say they're cutting down a tree or something, they drop their saw, the saw stays running, takes one of their legs off. The body is going to do some things in response to that, like constrict blood vessels in the area, or constrict blood vessels that are deemed less important. That's why their GI, your patient who's in true shock will have some GI complaints. They'll have stomach upset. Their fingers and stuff might be cold, because the body is working to divert blood away from places that aren't as important to keep oxygenated blood flowing to the heart, the lungs, and the brain. In order to do that, this smooth muscle will actually constrict and close off all that little vasculature, all that stuff that the brain has said, hey, that's not important, shut it down. And it will now begin to move blood back towards where things are important. Those blood vessels wouldn't be able to expand and contract like that if they didn't have this smooth muscle in it. When we talk about things like asthma or even anaphylaxis, or a patient who's having a severe allergic reaction to something, we're going to give medicine that will actually work on some of this smooth muscle to either expand things or contract things so that we can make our patient better. And that works on this smooth muscle that is around things like the blood vessels and around the internal structures of the lungs to open those airways up a little bit. And if the blood vessels didn't have that capability, we would have a hard time maintaining pressure. Now, we're going to get into cardiac and respiratory here in just a couple minutes, and all of this is dependent on pressure. The pressure of gas on the outside of our person versus the pressure that's actually in our chest on the inside of our person is going to be very, very important to actually being able to get that gas from the outside to the inside and ventilate. The pressure of blood in our vascular system. We took blood pressures and checked pulses yesterday. The pressure that is maintained in that system is going to be very, very important as to whether or not our patient's going to be able to pump around any of that oxygenated blood that just got back to the heart from the lungs. A lot of what our body does is really dependent on these smooth muscles and being able to maintain an adequate amount of pressure. So here we have the respiratory system. The respiratory system, the structures of the upper airway start outside, right at our lips. We have the nasopharynx, or the nasal passage. We have the oropharynx. We went over with Bryant yesterday about the oropharyngeal airway. That's the little scoop-looking thing that goes into our patient's mouth to hold their airway open. We also have an airway that we can put inside our patient's nose. Maybe today, actually, we'll work on that a little bit. We'll talk about and work on some airway stuff. But moving right on down, we get to the epiglottis. The epiglottis is a sort of piece of cartilage that's leaf-shaped, and it sits right at the top of your trachea, right at the top of your windpipe. And its job is to keep the trachea open when we're trying to take a breath and get gas in. And it is to close the trachea and direct food down into the esophagus and water down into the esophagus to keep that stuff out of the lungs. The lungs don't want to have any of that in it. Like, that's why when food goes down the wrong way, you cough like a madman and everybody thinks you have COVID. It's because the epiglottis, for one reason or another, was a little short on the switch and didn't get things closed. But it is meant to keep things out of the trachea and out of the lungs that are not air.
So that's like a backflow preventer.
Pretty much. Pretty much. The trachea carries the gas that has been brought in through the nose and the mouth down into the lungs. Right at the sort of top of the trachea, we have the thyroid cartilage, and we have the larynx that sits right behind it, our voice box. Our vocal cords sit right there, and we get further down into our patient's actual physical trachea here. And what you'll see about the trachea when we take a closer look at it is it's made up of cartilage rings. They're like 3/4 rings that are surrounded on the back by smooth muscle, sort of the anterior portion of our esophagus. They sit very, very close to each other in the chest. We're moving on down through our patient's trachea. We get to the right and left mainstem bronchi. Those right and left mainstem bronchi enter into the lungs at a spot called the hilum and continue to get a little bit smaller and a little bit smaller as they go along, and they eventually end in bronchioles. Those bronchioles get down to the bottom portion of this picture and the alveolar ducts where these alveolar sacs live. And from the outside of this patient, all the way down to these little alveoli, absolutely not one thing happens other than the movement of gas. This is all ventilation. This is all just moving gas from the outside to the inside. When we get down to these alveolar ducts and these alveolar sacs, this is where all the actual now gas exchange that keeps our patient running actually happens. When we bring gas in from the outside, we get it all the way down to these alveoli, and those alveoli have a lot of oxygen in them. The blood that has just been pumped out of the right side of the heart to these alveoli have already used their oxygen. The right side of the heart houses deoxygenated blood that has returned from the body after dropping off its oxygen. So the right side of the heart pumps blood out to these alveoli through the pulmonary arteries, because arteries travel away, and we wind up in capillary beds right next to these little sacs. There's a lot of oxygen inside the sac. There's only a little oxygen outside the sac in that capillary bed. Gases want to be equal. This is the bit of physics. Gases want to be in equal concentration on both sides of an equation. So what happens? The oxygen that's in the alveoli in a high concentration moves into the blood that only has a very low concentration of oxygen. Once that happens, carbon dioxide will move out of the blood and into the alveoli, because the alveoli have a low concentration of carbon dioxide and a high concentration of oxygen now. So the gases just swap past each other. The byproduct of actual energy creation every single second of every single day of the rest of your life is just carbon dioxide and water vapor. Those are the two things that are created. The lungs are responsible for this gas exchange and oxygenating the blood. The lungs are also responsible for elimination of those byproducts. So in this gas exchange at the alveoli, oxygen moves out, carbon dioxide moves in, everybody's equal and happy. We exhale and breathe out all of that carbon dioxide and water vapor, and our little drop of blood goes back to the left side of the heart to get pumped out to the rest of the body and wind up in systemic circulation to go and deliver oxygen. That is how the entire respiratory system and cardiac system work with one another. That is the nuts and bolts of this whole thing that we really are. It's metabolism. We are a metabolic machine. Oxygen and glucose are like gasoline. It's the two things that will keep us running forever. And we have to get those things from the outside to the inside. And our respiratory system is the way we do that, starting with just the anatomy of our airway. Don't worry, we're going to do that a lot of times today. You'll see pictures 100 times between today and the rest of this week. Did that make at least a little bit of sense, though, initially?
Yep.
All right. Moving right along, we're going to talk the structures of the lower airway anatomy here for a minute. When we're breathing, we're ventilating, we're getting gas from the outside to the inside. I told you it was all based on pressure. So what happens in this situation is my intercostal muscles, the muscles between my ribs, contract and pull my chest wall out. The diaphragm will contract and pull down and towards my anterior, so it pulls down and forward. And when I do that, I just made the closed loop of my chest cavity bigger, right? Those muscles contract and pull everything out, and in pulling everything out, I just made that space larger. But it's sealed. There's no ability for anything to escape from those internal pieces. Everything is sealed off. So when I make that structure larger, I decrease the amount of pressure that's inside. And when that pressure goes down, gas from the outside is going to rush down into my chest cavity and into those airway structures and down to those alveoli, and now equalize off the pressure with the outside atmosphere. So when my chest wall gets larger, the space gets bigger, the pressure goes down, gas comes in. I had to use muscle energy to do this, so it's an active process. That's how we get gas in. That's how we ventilate on inspiration or inhalation. It's based on the fact that I just made the pressure inside my chest cavity smaller than the pressure of the atmosphere around me. And that made gas come in to try and make things equal again. When it's time for me to exhale, all of those muscles that just contracted and made things bigger just relax and now make things smaller. And when that happens, the space gets little again, the pressure goes up, and now all of that carbon dioxide and water vapor is forced out past that epiglottis, and I exhale all of the bad air. That is the nuts and bolts of air going in and out. We move air in and out based on differences in pressure between the closed system inside of our chest and the air in the atmosphere around us. When we look at the airway of an adult versus the airway of a child, and I know we talked about this very briefly when we were doing CPR. The structures of a child's airway are smaller. They're nasopharynx, they're oropharynx, both littler. But proportionally speaking, their tongue actually takes up more room in the airway than an adult's does. When we look at the actual trachea, the windpipe of our pediatric patient, it's narrower than that of an adult, and it's less rigid. It's not as developed. Those cartilage rings haven't really had a chance yet to really form up and get strong. So it's narrower, it's less rigid, less developed. That means it's easier for us to obstruct it when we do things like the head tilt chin lift. When we talked to pediatric patients during CPR day, we talked about that neutral sniffing position and trying to put something sort of between their shoulder blades to make managing their airway a little bit easier. Because if you look at a kid's head, and those of you out there who have youngins, proportionally speaking, the head is the biggest portion of a kid. So it is actually creating an airway obstruction here in this picture, because the back of this kid's head resting on the floor like that is actually forcing his head forward and crimping his airway shut because it's narrow, it's less rigid, and it's more easily obstructed. So when we start thinking of some of the differences between pediatrics and adult, you look at some of just the physical anatomical differences, and it's easy to see why just laying a kid flat on the ground with nothing between his shoulders makes it a little bit more difficult for us to actually truly appropriately manage their airway. So here's a picture of what I just talked about with ventilation, because we really haven't done anything but move gas until we start talking about respiration. So ventilation, we're just moving air from the inside to the outside and from the outside to the inside. When I'm going to inhale, those intercostal muscles, again, they're going to contract and they expand my chest wall. They're going to now, at the diaphragm, contract and pull outward towards my front, towards my anterior portion. And I have now made a larger space. But I have made a larger space that's in a vacuum. So the pressure has gone down. The pressure is now smaller than the atmosphere outside. Gas rushes in to fill up all that excess space and equalize all of that pressure. I had to contract muscles to do this, so it is 100% an active process. When I want to get that same gas now out again, everything just relaxes. No muscle contraction, no energy expended. It just goes back to its resting state, and I make that space small again, which increases the amount of pressure inside my thoracic cavity. That thoracic cavity condenses, my ribs recoil back to their resting size, and I blow out all of that carbon dioxide, and air will continue to go in and out as long as that continues to happen. This is ventilation and ventilation alone. Now we're going to get into the bits and pieces of actual alveolar or external respiration. So I told you guys the cardiac and the respiratory system work hand in hand with one another. The right side of our heart is responsible for pumping deoxygenated blood to the lungs. So on the left side of our picture here, we're going to say right here where you see my little highlighter button, this blood has just left the right ventricle of the heart. This drop of blood is going to get pumped out of that right ventricle through the pulmonary arteries, because arteries travel away from the heart, and make it down to this alveolar capillary bed right here. And if that blood is deoxygenated, it's returned from the body and it's looking to pick up some more O2. That means it has a very, very small amount, if any, oxygen attached to the hemoglobin molecules in the blood. And if CO2 is the byproduct of now cellular respiration, it's got a lot of carbon dioxide. Inside of that alveoli, what do we have? What do we have a lot of?
Oxygen.
Oxygen. So on the blue side, on the left side of our diagram here, if we only have a little bit of oxygen there and we have a lot of oxygen inside the alveoli, the carbon dioxide moves this way, the oxygen moves this way, and after that happens, this drop of blood is now, instead of being deoxyhemoglobin or deoxygenated blood, it is now oxygenated blood, free to go back to the heart through the pulmonary veins and get pumped out into systemic circulation to go down to the cellular level and do the exact same thing in reverse. When we have now picked up that oxygen and been pumped out into systemic circulation, this blood here from the artery traveling away from the heart is looking to deliver some oxygen. We have a lot of oxygen here. We have a very small amount of CO2 in this blood. And then we get right next to the cells. Now we are at a cellular capillary bed. And what's the byproduct of this cellular respiration, this internal metabolism again?
Exchange gases.
Carbon
CO2.
dioxide.
Yeah, we're going to exchange gases, and yeah, it's CO2. So as we're working our way through this diagram, starting on the left-hand side, we have a lot of oxygen and only a little carbon dioxide, right? When we get next to this cell, what does the cell only have a little bit of?
Oxygen.
Oxygen. Yeah.
Oxygen. And it already used its oxygen, so it's got a lot of what?
Carbon monoxide.
Carbon dioxide.
Dioxide, sorry.
So the oxygen now, in order to make things equal again, is going to move into the cell. The carbon dioxide is going to move out of the cell. And then as we continue on our merry way here, this blood flow is going back through the venous side of our vascular system. It's going to wind up in the right side of the heart. And the right side of the heart is going to pump that blood back to this picture, where now this deoxygenated blood goes right back to this alveolar capillary bed, and it transfers carbon dioxide into the alveoli. Oxygen comes out of the alveoli. It attaches to the hemoglobin molecule. That hemoglobin in our red blood cells carries that blood back to the left side of the heart now, because the left side handles our oxygenated blood. The left side of the heart pumps things out into systemic circulation, and we wind up right back here. Wash, rinse, repeat. Every breath and every heartbeat of your person for the rest of your life. From the time you came out until the time they shovel dirt, this is the way that the whole thing works. So now I want to stop for a second. Did I blow anybody's doors off?
Yeah.
Okay.
Yeah.
No problem. We're going to go over this a lot, and I wanted to stop here for just a couple minutes because this is like high level stuff. This is a condensed anatomy and physiology class, and even though you might not get it right this second, we'll get it, I promise. So hearing that just sort of took the wind out of some folks. Why don't we, wow, it's almost another whole hour since we got back. Why don't we take another 10-minute break, and we'll come back and run through the rest of this. And when we come in today, we're still going to do chapter 2. We still got plenty of time. But I'd rather walk this back a little bit and go slow here, because this is important stuff, but it's also not the easiest thing that we're going to look at. Why don't we take 10, and when we come back, we'll finish this lecture. We'll do chapter 2, and anybody who was wildly confused by what we just went over, we'll clean it up when you guys get here today. All right?
Yes, sir.
All right. Thank you.
No problem. All right, everybody, we're back. Or I'm back anyway. Is anybody out there?
I'm here.
Yep.
All right.
Yeah.
Hey, quick question.
Yep.
Going back, I was just reviewing my notes. Just going back, just correct me if I'm wrong here, but you're essentially talking, when you're talking about the exchange of carbon dioxide and oxygen, both in the alveolar sacs and the cellular level, it's essentially the same process, just two different locations, right?
It's exactly the same process. It's just two different locations and the concentrations of one versus the other change.
All right,
So
thank you.
once the blood has dropped off its oxygen and goes back to the right side of the heart and goes to the lungs, it's got like no oxygen and a lot of CO2. Once it offloads that CO2, picks up oxygen, goes to the left side of the heart, it goes out in the systemic circulation, eventually makes its way down to the cellular level. Now it has a lot of oxygen. The cell has a lot of CO2 and only a little oxygen. So everything moves the opposite direction and goes right back to where it started, right back to the right side of the heart to go to the lungs, to drop off all that stuff and just keep going round and round and round.
So it's a constant exchange of two different areas.
Yep. Yep. In the lungs, we're exchanging carbon dioxide out and oxygen in. And then in the cells, we're exchanging oxygen in and carbon dioxide out. So the oxygen moves into the cell, carbon dioxide moves out of the cell. In the alveoli, oxygen moves into the blood, carbon dioxide moves out of the blood. Did that answer your question?
Definitely, thank you.
Yep, no problem. So we know we need to have an adequate supply of oxygen in order for all of this stuff to continue to function. Some things that are going to show us that breathing has become inadequate are going to be a respiratory rate that is either too fast or too slow. We'll see cool, clammy skin, so patient will be sort of cool to the touch or have that sort of just wet, kind of moist look to them when they're just sitting there minding their own. You know, we're not talking about somebody who's out playing basketball. We're talking about someone who is just sitting in their living room like this guy right here, and breathing has turned into so much effort that they're actually breaking a sweat.
Is that what cyanosis is?
So cyanosis is a change in color.
Okay.
Cyanosis we'll start to see, especially in the early stages. We'll see it in the nail beds. We'll see it around the mouth, and their skin is actually blue in those spots. And it really, it's the damnedest thing once you see it, because when we look at people as a whole, even the people with the darkest skin pigmentation imaginable, nail beds are pink, mucosa around and in the mouth is pink, underneath the eyelids is pink. When we start to see people turning blue in those spots, we can really put our finger right on the fact that at least breathing is inadequate, and probably the respiratory and circulatory system are becoming pretty markedly inadequate. Because the only thing that's going to make somebody blue and cool and diaphoretic or clammy are going to be problems with respiration, ventilation, or cardiac. Those are some things that we see that start pointing us towards a perfusion problem again. Remember, the body just struggles and strives and works towards always having an adequate supply of oxygen and glucose available to the cells. And anytime that's not happening the way that it's supposed to, we're going to see much the same signs and symptoms, regardless of what the actual reasoning behind it is. It presents a lot of in the same way. So we'll see some changes to skin color. Maybe our patient is pale. Generally, they don't go right to cyanotic, that bluing. They get a little pale looking first, and then they'll go cyanotic. Or maybe we'll start to see some changes in their respiratory pattern. Now, yesterday when we were working on vital signs and we talked about counting respirations, if you look around at people breathing, one thing that you notice about it is when it's working the way that it's supposed to, it's very unremarkable. You don't notice a lot, you don't see much. It's just chest goes up, chest goes down, chest goes up, chest goes down. Breathing at its base is supposed to be noiseless, effortless, and painless. Anytime we see or hear noise, effort, or discomfort when it comes to breathing, guess what we've found? We have found inadequate respiration, period. Because normally speaking, people don't have to sit in this right here. This is the tripod position that is on here somewhere. This is obviously abnormal, right? And then you think of the way this guy's neck muscles look right here. And you start to think, all right, well, that looks like a lot of effort. It looks like he's working really hard. Does anybody's neck bulge out ridiculously when they're just sitting in their living room breathing? No, so we're using some accessory muscles. We're looking for nice, good, even, adequate chest rise and fall, and maybe his respiratory rate has now become so fast that his chest barely moves when he breathes. If we have all that space where none of the gas exchange that keep us a functioning human takes place, if we don't see that adequate chest rise and fall, what's not truly happening?
Just not getting enough oxygen.
He's not getting enough oxygen because we're not getting oxygen all the way down to those alveolar sacs and those alveolar ducts for the gas exchange. All of that gas, when we only see a little chest wall motion, is staying in that space where no gas exchange happens, no actual transfer of oxygen and carbon dioxide happens, and the cycle breaks because we're not actually now supplying the needs of the body. So we'll see a fast respiratory rate. We'll see some increased effort. We might even see some irregular rhythm. We'll start to see some changes in my patient's skin color, temperature, and condition. And it's all just based on the fact that their breathing has become inadequate. Inadequate means it is no longer meeting the needs of the body and sustaining our patient. And sure, will the body do that for a little while? Absolutely. There are some failure mechanisms built in. There's some things that the body tries to accomplish physiologically that will make it so that the minute your breathing becomes inadequate, you don't keel over and die. But all of the things that the body does to try and make this better only last for a little amount of time. Let's look at probably the easiest one to describe it. The use of accessory muscles. What that means is when the body is under attack and breathing has become inadequate, the body recruits muscles that aren't normally responsible for the work of breathing to try and breathe better. So if you all of a sudden don't go to the gym for a really long time and then think you're going to work out like you're 17 years old and bulletproof again, what happens?
Yeah, like massive chest pains, cramping could occur.
Yeah, and really more than anything else, you're a lot more tired. You wind up a lot more out of breath. And it's because those muscles aren't used to carrying the load. They're not used to actually having to accomplish that work. When your body recruits accessory muscles in an effort to try and accomplish the work of breathing better, Those accessory muscles aren't used to carrying the load. They aren't used to accomplishing that work, and they wind up demanding more oxygen. So if my breathing is already inadequate, and one of the things that my body triggers to try and make my breathing better winds up demanding more oxygen, what do you think happens?
Take a shot at it, pass out.
We don't even have to get that deep into it. If the muscles aren't used to it and they're demanding more oxygen, and oxygen is already the problem,
They're not going to be as efficient.
they're not going to be as efficient. They're not going to be as effective. They're going to tire out faster, which means my patient's inadequate breathing is going to do what?
Decline.
Just get worse.
It's just going to get worse. And you start to see now, instead of 1 or 2 signs of inadequate breathing, now we start to see this whole shooting match popping up right in front of us. And we can actually physically watch our patient get worse just by some of the things the body is doing to try and make it better. So any of those failure mechanisms, whether it's cardiac, whether it's respiratory, or any of the other sort of assistive measures that the body tries to take to make itself better, they have a time limit. They're only going to work for so long. They're only going to last for so long before they start feeding the problem. And that's sort of where we earn our keep. Because if you start to notice things like, well, my patient is breathing really fast and the breaths are really shallow, so I know they're inadequate, but now I'm starting to see this guy fighting to actually breathe, and we're starting to see, all right, now we're seeing real big retractions, or where you can see contractions around places that aren't normally responsible for breathing. So like the neck, the clavicles, those intercostal spaces between the rib cage. You don't normally, I mean, if you watched yourself in the mirror breathe, you'd see none of this. But if we see our patient doing it, we know that now the body is really in its last ditch effort trying to compensate. And before long, all of those compensation methods are going to fail. And when those methods fail, the patient goes from respiratory distress, because if you look at all of this stuff, it seems like it would be pretty distressing if this was the way you had to breathe, right? To respiratory failure. Failure means the body is now not doing it really at all successfully. And it's going to tell us what we need to do to treat the patient. If we back this off a little bit and say we only see a couple of these problems. My patient's just in respiratory distress. They're having some shortness of breath. But the more negative things we start to pile up, and the more problems and the more problematic things like use of accessory muscles or having to position themselves so that they can breathe appropriately, we know that we're getting closer to the end of the string here, and my patient isn't going to do this for very long, because all of these things are going to demand more oxygen, and more oxygen is not even an option right now. So now we've reached the circulatory system. Looking at the heart here, the heart has 4 chambers. We have the right atria and the left atria that sit on top of the heart. The job of the atria is pretty much just to be a storage tank for blood. The atria don't do a whole lot of pumping. They're not as muscular, they're not as thick, they're not as positioned to actually eject blood from the heart. The right atria receives deoxygenated blood from the body, holds it until these valves here open again, and then it goes down into the right ventricle. Ventricles are responsible for pumping blood out. So we have the right ventricle and the left ventricle. There's your 4 chambers, right and left atria, right and left ventricle. The right atria the ventricle takes that deoxygenated blood from the right ventricle and pumps it out through the pulmonary arteries away, and we wind up in those alveolar capillary beds where that initial external respiration, that alveolar capillary respiration takes place. So that blue blood there has a lot of CO2, and it gets next to those alveoli, and the carbon dioxide moves out of the blood and into the alveoli. The oxygen comes out of the alveoli and into the blood. That gas exchange is complete, and we now have oxygenated blood, or oxyhemoglobin. That oxyhemoglobin now is where this turns red and goes into the pulmonary vein, because veins travel back to the heart. We wind up in the left atria. The left atria just holds onto that blood, eventually deposits it down into the left ventricle. The left ventricle will contract, force out that oxygenated blood into the aorta. The aorta brings that blood downstream, all the way down to these capillary beds surrounding the body cells and tissues. Those cells have already used up their oxygen to try and create the energy that they need. So the byproduct of that energy creation is carbon dioxide. When our drop of blood gets down here, it has a lot of oxygen. The cell only has a little bit. We have almost no carbon dioxide. The cell has a lot. The carbon dioxide moves out of the cell and into the blood. The oxygen moves out of the blood into the cell. And we wind up back over here on the blue side to eventually get to the vena cava and right back to the right ventricle. So this is how the respiratory and the circulatory system work together to make all of this stuff happen. It's every drop of blood, every minute for your entire life. We go right atria to the right ventricle through the pulmonary artery, out to these alveolar capillary beds. The right ventricle pumps deoxygenated, highly carbon dioxide laden blood to those alveolar capillary beds. That gas exchange takes place. We now have oxyhemoglobin, or oxygenated red blood. That oxyhemoglobin right back to the heart through those pulmonary veins. We wind up in the left atria, down into the left ventricle, out through systemic circulation, and right back down here at the cellular tissue level for time immemorial. This just goes round and round. And this is air goes in and out, blood goes round and round, and any deviation of that is bad. I'm going to come up with a bit more sort of linear straight line breakdown of this for you guys when you get here today. But did going over it an extra time with maybe something else to look at kind of make this a little bit better to any of the people who were wildly confused when we went on break?
Yes.
Yeah, definitely.
Seriously, because this is something we could, as far as I'm concerned, if we can nail this down, I would be perfectly happy to spend the rest of the day on this. So
You mean nailing down just the circulatory system?
if we could nail down circulatory, respiratory, and gas exchange, that is like about as big of a concept as we're really going to get into for all of this anatomy and physiology lecture, because every single chapter that we're going to talk about is going to do a little bit of anatomy and physiology anyway, but these are probably some of the higher level, more difficult things that we're going to talk about. And if you can understand this when we do the shock lecture at the end of the week or beginning of next week, whichever it was, it's gonna be like somebody flipped the light switch and you're gonna go, oh, that's why all of this makes sense. So I would much prefer to spend extra time with this than to move on and try and do anything else.
I agree on that.
Sounds good to me.
I'm just trying to find one other thing. And I found it. So I mentioned the cell's job is really just to create energy. And when it does that with oxygen and sugar, we call that aerobic metabolism. Aerobic metabolism is how the body functions the best. It creates the highest amount of energy, and it creates the least amount of waste product. It creates nothing but carbon dioxide and water vapor. When the body switches to one of its failover mechanisms called anaerobic metabolism, anytime when we talk in terms of medical terminology, we see the letter A or AN in front of something, it means lack of. So apnea means lack of breathing. Arrest or cardiac arrest means the heart's not beating. So when we talk anaerobic metabolism is just the name of the process that takes place when the body doesn't have an adequate supply of that oxygen and sugar that it needs. And if it doesn't have enough of it, it switches over to anaerobic metabolism to create energy for itself. Because in order to carry out their mission, every single cell needs to create what is called adenosine triphosphate, or ATP. That is the little lightning bolt for every single cell in our body. If we are in anaerobic metabolism, because we don't have oxygenated blood flow to these cells, on top of the carbon dioxide that it would produce normally, which is acidic to begin with, it produces things like lactic acid and a whole bunch of other cellular byproduct. All of that becomes very, very acidic, and from there on out, even if we restore oxygenated blood flow, those cells, after they've been steeped in acid for long enough, may have actually just filled with that acid and eventually exploded. So we'll have this anaerobic metabolism filling these cells with acids and filling these cells with all this waste product. And if oxygen isn't being delivered, none of this waste product is being carried away. And those cells will just sit there for a while until they've had enough of being surrounded by all this acid. And then one by one, they do something called lyse. Lyse just means explode and die. Once enough of those cells have been steeped in acid and they all explode, then we have entire pieces of tissue that will do the same thing, because this anaerobic metabolism is continuing and continuing and continuing, and all this waste product is being just built up. And then once enough pieces of tissue actually die, we'll have entire organs die. And once enough organs die, the entire metabolic system that we call a body will break down and die, just based on the fact that there wasn't enough oxygen and there wasn't enough glucose and there wasn't enough byproduct being removed. And that's why when you hear me mention, just like off the cuff, air goes in and out, blood goes round and round, and any deviation is bad, this is how it gets bad. This is like pretty clinically the body's march towards death. We have cells that can't create the energy they need. When they do create any energy, it winds up being a negative anyhow. We have all this acid being built up and stored all around. And sooner or later, that acid makes cells die, tissues die, organs die, and organism systems die, just based on the fact that when we get to the cellular level, this blood here from the artery isn't coming. There's a blockage somewhere. So we got a bump in the road right there. And that blood is no longer able to deliver its oxygenated blood to this cell, which means no O2 is getting delivered, no CO2 is getting picked up, and the garbage all just piles up in the street. And sooner rather than later, this cell dies, and this cell dies, and this cell dies, and this cell dies, and your patient just continues to get worse and worse and worse and worse, just based on the fact that we ran out of adequate supply of oxygen. And that is really sort of the long and short of death, even from something else. When your patient goes into cardiac arrest, they have no pulse, they are not breathing. So that right there tells me that gas is not being brought in from the outside. If gas is not being brought in from the outside, it's not getting down to those alveoli. If oxygen-rich air from the outside is not filling those alveoli, and blood is not being pumped by the heart through those pulmonary arteries, I know that there's going to be no blood moving. And if there's no blood moving, none of that oxygen that's in there is getting sent anywhere. So the problems just continue to pile up. And it's all really tied right back to the fact that the alveoli need to be oxygen rich to oxygenate the blood at the alveolar capillary level. And then when we get down to the cellular level, here in this picture right here, this oxygen-rich blood needs to travel and drop off its oxygen here, pick up this carbon dioxide here, and just continue right back to which side of the heart are we going to here?
Right atrium and right ventricle.
Absolutely. And after we get to that right atrium and right ventricle, what happens next?
Travels to the lungs.
Keep going.
To repeat the process and then get into the left side.
Absolutely. And there you go. Blood's going round and round. So we switch back from this anaerobic process to aerobic metabolism, and everything just keeps clicking along perfectly well. The alveoli will get a lot of oxygen in them. The blood will have only a little bit of oxygen in it and a lot of carbon dioxide. And those two gases just spend all their time, eternity, swapping back and forth from one side of this equation to the other. The alveoli, lots of oxygen. The cells, only a little oxygen. So it's got to get from the lungs to those cells. Blood is the way that it gets transported, and pressure is the reason that all of this happens. That's really that's kind of the way it goes.
Like a bus picking up people and dropping them off, correct?
Absolutely. The blood in and of itself really is just the T. Its job is to move things from point A to point B, and then from point B back to point A at the end of the day. So if that's the way it helps to think about it, sure, the blood and all of this is really just the MBTA. All right. So here we go, Chapter 2, Workforce Safety and Wellness. First thing we're going to talk about is some of the emotional aspects of emergency care. So this really pretty much mirrors the 5 emotional stages of death and dying, which is something that we're going to deal with as providers and really just as people. When people are dying, especially when people know that they are dying, it was a doctor by the name of Kubler-Ross who came up with the 5 stages of death and dying. The first one's denial, generally. They don't always follow in order, but generally the first thing that happens when somebody finds out that they are getting towards the end of life is they don't believe it. Not me, I got plenty of years left. Denial is just that. It's just they absolutely refuse to believe that they are getting to the end of the string, and they don't have too many more sunrises in their future. After that, generally following is anger. People, when they clear the denial stage, generally do wind up pretty mad at anything, at anyone, and about pretty much, you know, the wind blowing. It doesn't really matter, and it's not really, you know, true anger. It's not really directed at anyone in particular. It's sort of just anger for anger's sake. Generally speaking, anger is just trying to mask other feelings, generally sadness, especially when you are faced with your own mortality. Then these other stages tend to happen out of order, right? Bargaining and depression can happen either way. Depression, that makes sense. The patient is just sad about the fact that they're not going to be around for much longer and they're with their loved ones and able to enjoy life anymore. Bargaining are the things that they come up with that they haven't gotten to do yet, and that they will be okay with the fact that, yes, I am getting ready to pass away, as long as I get to see my kid graduate college or walk my daughter down the aisle. So the bargaining stage is that never got to do list that people come up with, and that if they could just accomplish this. I always wanted to see the Great Wall of China. If I can just go on that one last trip that we have scheduled for 2 months from now, I'll be okay with this. And then last but not least is probably, I would say, the more freeing for the person who's actually doing the dying. When they have gotten to the point where they understand that, yes, all the denial and all the anger and all the bargaining and all the sadness in the world isn't really going to change what's going to happen. And they sort of just get to the point where it's, well, you know, I've lived a good life, and if this is the end, then this is the end, and we'll see what happens next. You know, they still are there for their family at that very given moment in time, and it really brings them to the point where, you know, the family will see somebody who's okay with what's going on. So it sort of helps begin the healing process for the family. Because especially in situations where we're dealing with a patient who knows that whatever it is that has happened to them or whatever it is that they are suffering with is incurable and not going to be a positive outcome, the family and friends are generally the ones we wind up providing a lot more of the care for. People that are on, say, hospice care, you know, they are at the point where they know that their life is drawing to a close, and there's really not a whole lot that they're going to be able to do about it. And even if the patient themselves becomes okay, the family a lot of times isn't, and they're most of the time the ones who need a bit more support than the patient does. You know, the patient is still our priority, but they may not really need, require, or even want any of our assistance. We can put a little bit of our focus towards making sure that the family is adequately and appropriately taken care of. Some of the things that we need to be cognizant of and make sure that we are sort of doing or not doing, always maintain the patient's dignity. It becomes very, very easy to accidentally, I would say, since people are uncomfortable in these situations, talk about someone while they're still right there in the room. So, you know, you're talking to the family about the patient who's right there next to you and still conscious, alert, oriented, hearing and understanding every single word that leaves you. You know, treat everyone as a whole in that regard. Talk to the patient, maintain their dignity, but also let the family in and be part of the whole care team. That goes right along with showing them the due respect. You know, they are still a viable human until the point where they go into cardiac arrest if they're on sort of hospice or do not resuscitate most orders. Just talk with them. You know, these aren't people that you're going to be doing a whole lot of skill on. You're not going to be, you know, necessarily even taking a whole long set of vital signs every single time to try and figure out what can I do for this person? Because the answer is there is nothing you can do for this person. Medical science has gotten to the point where there is nothing left that can be done or accomplished to make this person better. So something just as simple as chatting with them on the ride to a hospice or from the hospital to their house to go home on hospice is worth its weight in gold. Don't give false assurances. I myself have been guilty of this. I remember like it was yesterday. I dropped a hospice patient off doing just a regular run-of-the-mill transfer. We picked him up at a local hospital, and I was bringing him to a hospice place where he was going to die. And you know, it was a nice trip. We had a nice talk. Bring him in, put him in his bed, and I said, "All right, have a good one. I'll see you around." And I remember I stopped dead in my tracks and I'm like, you just told a hospice patient to have a nice day and that you'll see him soon. And luckily for me and my pride, the patient started to laugh, because I'll tell you, nobody felt like a bigger donkey at that very given moment in time than this guy sitting right here talking to you. Tell them like it is, because they know the score. So giving false hope and coming up with all those, oh, don't give up, you know, you'll be fine. Somebody with a whole lot of letters after their name have already told these folks that they are not going to be fine. So don't try and convince them otherwise. If they're still fighting and they're still trying to beat whatever it is that has made them sick, absolutely have their back. But giving false assurances like, no, you'll be okay, don't worry, just keep after it, isn't really where it's at. So that's the stress, and the stressors on us from the patient side. Next thing we're going to talk about are some things that you think might provide for stressful situations just in general. So let's get into some of this for a little bit. We talked briefly about multiple casualty incidents because of some of the questions that were in, I believe it was Chapter 3. But why do you think on the list of things that, because they actually polled emergency service providers on this, why do you think mass casualty incidents or multiple casualty incidents made the list so high?
Because you can't help everybody.
Say it again, because you're right.
Because you can't help everybody.
You can't help everybody, and you know that the minute your feet hit the ground, that not everyone is going to get out of this okay. And there's going to be nothing you can do to change that. There's going to be nothing you can do to make that one bit better, other than in a mass casualty incident, we do the most good for the most amount of people. Some people just don't get saved in these situations, and there's not a thing we can do about it. What about emergencies involving children? What do you think makes that a stressful call?
It's because of kids. They're innocent. They're don't have a whole life to live.
Mm-hmm. Absolutely. And then I'll add another little piece to that. How many calls do you think we get percentage-wise that are really, really like critically ill or injured children?
Not a lot. They're most of the time they're very healthy. They don't, have cardiac arrest issues. They're not diabetics, not slamming cheeseburgers. They heal pretty quickly.
It's like 1% of our call volume. Only 10% of our entire call volume really normally has to do with kids at all. And only 1% total is critically ill or injured children. So this is not something we see an awful lot of. So you add to that now the additional stress of not only is this, like you said, a kid that's got their innocent, they got their whole life to live. They haven't really even had the opportunity to do anything to put themselves in this jacked up situation. Now you have to think and go, Jesus, when was the last time I even looked at a sick kid, let alone had to transport and treat and do all the things that I need to do to make sure this kid doesn't get any sicker? And it just turns everything up to 11. Moving on down the list, now let's talk some about other stuff. Now, this isn't really patient-centered, is it? Injury or death of a coworker. What do we think about that?
Horrible.
Right?
Must be pretty rough.
Not you. I mean, we'll peel the veil right now. You look in the mirror and you can see yourself standing next to that person at some point.
Yeah, and everyone pretty much becomes family over time.
Right. I worked years where I spent more time with some of my partners than I did with my own flesh and blood. So you guys become each other's extended family. You know, it's definitely one of those things where, you know, you look around the dinner table and somebody's missing, and it becomes the elephant in the room, and it becomes a difficult thing for people to deal with. You guys all pretty much being from Everett have a pretty good opportunity to have this next one happen. I will tell you personally that I have never, ever, not once in my life, worked in a city where I lived or grew up, because responding to calls that involve friends and family members, I don't enjoy. You know, I like to fancy myself a pretty good field provider, and I would want someone like me to take care of my friends and family, but God damn it, I don't want it to have to be me, because I'm not mentally prepared for the downstream from that. You know, great, I can do the things that need to be done and accomplish all the tasks that need to happen when you are sick, but after it, if the outcome was bad, you have every opportunity when you wake up in the morning and look in the mirror to beat the ever living crap out of yourself for the rest of your life, because, you know, you responded to your best friend from childhood's house on Christmas morning and his mom was in cardiac arrest right there underneath the Christmas tree, and you couldn't make the save. Forget that. And then the last little thing we're going to talk about here is calls that involve abuse. Now, this is another one of those things that is not my jam. I don't understand for the life of me why people just can't be nice to each other, but apparently they can't. Calls that involve abuse are a violation on a couple of fronts, because first of all, for the most part, all of these are voluntary relationships. You know, even if it's an elderly family member or a spouse or a child, rather than be an abusive jerk, you could always just leave. I don't understand that mentality, first of all. And then second of all, you take the fact that now you are someone that you're supposed to love and take care of and be there for. You are going to treat them in an abusive fashion, whether it's mental, whether it's physical, really makes no difference to me, because it is now the second half of the violation of that whole thing. And these are not my favorite things to be involved in. It's just, it adds to and sticks out as some of the top 5 more stressful things that we can be exposed to as emergency service providers. So the next thing we're going to talk about is the actual stress reactions inside of our person, because stress is not always a bad thing. Stress is split up into distress and eustress. EU stress. Eustress is what actually helps you get through a stressful situation. Your body has a very immediate reaction to stress. Your body will release a whole bunch of epinephrine to stimulate that fight or flight response. Am I going to fight that bear, or am I going to outrun it? And that epinephrine will do things like constrict your blood vessels so that your blood pressure goes up some. It will actually make your heart beat faster and your respiratory rate faster, So you're supplying all that oxygenated blood and getting all that blood oxygenated so you can prepare to fight that bear off or run away from it. That acute stress reaction happens momentarily. It happens right away. Generally, they can come along with some cognitive type issues because the brain doesn't always function so well when it's dripping with epinephrine. But it is something that actually drags us through that stressful situation. And then the flip side of that is the body releases some chemicals to now turn that epinephrine off so that when the stressful situation is over, we don't run around like crazed lunatics for the rest of the day. We can actually begin to sort of ratchet it back down a little bit. And that is how we respond to a stressful situation positively. That's what our body was meant to do. That's the way everything is wired. And that eustress is meant to protect us and drag us through the suck. When we start to see delayed stress reactions, though, we have some issues to talk about here. Because we've already been exposed to that high stress situation. We've already gone through the acute bit of it. And that high stress incident sort of sticks with us. And maybe a couple days or maybe a couple months or maybe a couple years afterwards, we start to see things like nightmares, irritability, insomnia, trouble sleeping, flashbacks, all the things that point us towards now that stress has become so life altering for us that we start talking about things like PTSD and actually needing to seek help from a qualified mental professional. Let me ask you a question about some of the symptoms that I just rattled off here. I'm going to go through them again. So nightmares, irritability, insomnia, difficulty concentrating, difficulty sleeping, flashback, increased interpersonal conflict for no reason. So you just decide to fight with everyone. If somebody else was telling you that they had all those things going on in their life, would you be worried about them?
Yeah.
Absolutely.
All right. So now I'm going to turn that question. Why are we all so good at ignoring those goddamn things when it comes to having to look in the mirror and think about the person looking back at me?
Disbelief. Some people don't want to put themselves in the middle of it and make it part of their problem.
Pride. You don't want people to think you're weak.
I'd say coping too. It's like a coping mechanism.
So we're going to talk coping mechanisms in a few minutes, but I'll latch on with the pride one, and I'm going to ask you a question about coping mechanism. It is a coping mechanism. Is it a positive one?
No.
No, because you're suppressing like actual feelings.
Yeah, because after that delayed reaction and all those warning signs that our body and our brain are trying to give us and that we are handily ignoring, then it's cumulative. And those stressful situations just pile up and pile up and pile up. And you get to the point where you are burnt out and can't do it anymore. And your anxiousness goes up, your irritability goes up. You may have complete and total physical and emotional exhaustion because we ignored all the things in ourselves that we just admitted would make us concerned if somebody else was telling us about them. Anybody see where I'm going with this?
Yeah, you'll end up giving a lot worse care to your patients and your partners and yourself if you don't tackle those problems head on.
Yeah, we can't just ignore this stuff with ourselves because it gets even deeper and it gets even worse than just being a crappy EMT or a crappy firefighter and being somebody that nobody wants to be around.
Suicide.
It gets even worse, right? This is how people, and this is how really suicide has become such a huge problem in the field of emergency services. It is something that, we all choose to ignore because we would all choose to ignore all of these signs and symptoms presenting themselves in us. But it's real easy to be like, oh yeah, did you hear about Bob? Bob's having a real tough time. He hasn't been able to sleep in a month. He hasn't, he's been arguing and fussing and fighting with everybody that walks upright. He's seeing that poor old lady in his sleep. And then you sit there and you go, well, shit, I was on that call with Bob and I'm having all those things too. Boy, Bob sounds like he's got a problem, but I'm okay. It doesn't make any sense. The first person you need to worry about taking care of is you. It's got nothing to do with the guys you work with. It's got nothing to do with the patients you take care of. It's got nothing to do with pride. The minute you start letting some of this stuff pile up on you and not go off you like water off a duck's back, the minute that happens, it's time to start evaluating things. Because I like you guys. You seem like a decent group of fellas. I don't want to have to think about the fact that sometime down the road, you're going to have these issues. Because I'm sitting here telling you, if you ignore them, it is like it's sitting on top of a ticking time bomb. And I'm telling you even further than that. You can shoot me a message morning, noon, and night. And if it's got something to do with anything that's of this nature, I'll be on the next thing smoking towards Everett to come and have a chat with you. Because I've been to enough funerals. I've seen bad things happen to enough people that just chose to be like, meh, I'll get better. Meh, so I drink too much. Meh, I started using. Maybe I'll jump off the Tobin. All facts. I know people that have done all of these things, and it would have taken one phone call, and it wouldn't have had to happen. And it's all because they chose to ignore things that would be concerning if somebody else was telling them, because their pride got in the way and they wouldn't reach out and talk to somebody about, hey, this sucks. Because it takes a whole lot more guts to stand up and be like, hey, this sucks, I need to talk to somebody, than it does to just bury that and let it eat you. Because in the end, you just let it eat and devour and chip away at your person. You just gave up. You just quit, right? And there's no other two ways to look at it. You can either fight or you can wave the white flag. There's only two options. So if you start to see some of these things, get in the fight, because giving up is a dead end street. Now let's see if there's anything else useful in this lecture. Yes. So we talked about coping mechanisms. And in case you hadn't noticed, I am not the exact epitome and picture of healthy coping mechanisms. I'm not going to tell you to get on your pedal bike and ride cross country. What I am going to tell you is our body's a machine. Garbage in, garbage out. We don't take care of the machine's not going to take care of us. The best things you can do to cut stress is to take care of yourself mentally and physically. If you feel things starting to get off kilter a little bit, take a look at what you're putting in. Diet is hugely important. Lean proteins are best. Try and limit the amount of sugar and caffeine and alcohol and things that are just crappy food that you put into yourself. If you can buy it at a convenience store, you probably shouldn't eat it. If exercise is your thing, exercise more. Exercise releases endorphins inside your body that they are structured for the sake of making you feel better. That's what they do. So if exercise is your thing, do more of it. If exercise isn't your thing and you like to spend the afternoon sitting by a lake fishing, do more of that. Self-medication is looking for your problems in the for the solutions to your problems in the bottom of a bottle. I can tell you, I've looked in a lot of bottles and they don't friggin' live there. The solution to your problems is elsewhere. This is a dangerous, dangerous thing that a lot of people in emergency services sort of fall into. I was one of them. I'm not going to sit here and pretend that I wasn't. If you want to chat about it sometime, we can. Do the things that you need to do to take care of you, because in doing that, in protecting your mental health and being responsible to you, it will make you a better firefighter. It will make you a better EMT. And on top of it, it will make you a happier, healthier person to stuff outside of work that matters. Because at the end of the day, you guys, now I understand firefighters probably look at this a bit differently than I do. Because some of you, I know there's a family history of firefighters and there's a long line of firefighters that went in front of you, and it was pretty much a lead pipe conclusion that you were going to be a firefighter because that's what your family does. I get it. But the minute your job becomes who you are, not what you do, you need to start looking at some priorities. Because I will tell you, the minute my job as an EMT makes my life outside of being an EMT miserable, I'm going to quit. Because there's no amount of money or benefits or pension in the world that is worth making me a miserable human again, just to put a roof over my head and food on my table, because I've always managed to do that anyway. Keep a work-life balance. Do not allow what you do for a job to take over. And as far as like beating yourself up for mistakes and things of that nature, we're people, we're not machines. Mistakes are going to happen. There's no reason to Monday morning quarterback yourself all the time about everything. As long as you do your duty, there's no real reason to look back. You ever wonder why the rear view mirror is so small and the windshield is so big? Because you're not going backwards. You don't need to look that way. You're going forward. Windshield's big for a reason. Some of the other things that get a bit kind of troubling for the career path you guys are working your way onto is our families don't get it. Unless someone in your family or in your household is an EMT, a firefighter, a cop, whatever the case may be, it's difficult for, families to understand why we put ourselves in the situations we do, why we do what we do, why we see the things that we see. I can tell you, you guys in very short order will be able to ruin a nice family get together with one story. And it won't even be on purpose. Somebody will ask you, oh, hey, how was work the other day? Well, we found this guy in his bathtub dead. He had been there for a week and it looked like human stew. Oops. So understand that as much as we need to have, we need our families to have our back, we need to have a little bit of understanding with them too. You're going to get called in on your day off and miss important life things. Or maybe you couldn't get the day off and have to miss a planned day trip or family party or a cookout or something. As much as we need our families to be there for us, you also have to have a little bit of the other side of it as well. We have to take care of things at the ranch in order for our lives and your lives as firefighters to be good ones. And keeping that work-life balance and keeping all of these things sort of put together and in the proper priority fashion is what's going to pay dividends, because you guys all got long careers ahead of you.